Dr. Kumar, doctor, a fantastic, proficient surgeon and great teacher at that. He'll be talking about managing the hard nut. Kumar.
Good morning, everybody, and thank you, Maipal, for this opportunity in this fantastic course. Can I have my slides? Thank you. So I'm going to show you a case, and I want an active participation from the audience. So let me show you the right eye and the left eye, okay? So you use any slit lamp. I also have a photographic slit lamp from Topcon, and any slit lamp you try to put light from the front part, it won't penetrate the anterior 1/3 of the nucleus, and you can't see the posterior capsule at all. So anything, any full power, nothing, you could not go beyond this to even see it. So this is one eye. So now I'm going to have active participation from the audience because I'm going to ask questions, and then I'm going to tell you what I really did. So question here is, what will you give him or her, which IOL? Okay, because this is the case you can see, very, very hard cataract. You can see the anterior capsule, and beyond that, it's only the nucleus. You can't see the posterior capsule at all, okay? So will you do an ECC, SICS, ICC, phaco, flax, or phaco only? Anybody from the audience? Quick answer, because I have to finish in 7 minutes. Nobody? Flax. Yeah, these flag guys will talk only flax. Nobody from the panel I'm going to ask. So anybody from the audience, because I did a similar thing in BOA, and the whole panel said SICS. So if someone can wait this long to get a cataract, is not in a hurry to have early visual rehabilitation after surgery. So the next question is, can you refer this to your best neighbor and forget about it and wish them best of luck?
You can refer them to Delhi also. Maybe we are not neighbors. So,
okay.
Kumar, the question here is SICS for people like me who don't know how to do SICS, we'll do ECC?
See, I don't know SICS. I'm good at ECC. I'm sure you must be in the same boat.
Yeah.
I don't think you know how to do SICS.
No, I don't.
It's the same as me. So some of us never learned SICS. We learned ECC, and then we went straight to phaco. But now the next question is, what did I do? So you can see that it's a completely black cataract. There is absolutely no glow. There is nothing you can do about this. And I'm going to ask you questions again. So let's see what I did. So you can see that I did flax, okay? But you can see there is no glow at all. I mean, this is the hardest cataract I have ever done in my career. And so did Virion, okay, went ahead. Of course, very important, and I think Mahipal mentioned this, when you have a black cataract, like you have a white cataract, and you do flax, it's very, very important to use the dye. The reason being, sometimes you may have some tissue adhesions, or the CCC may not be complete. In that case, even if you increase the energy of the CCC, you may miss it out. So here you can see that I put the dye, and I'm using a viscoelastic. Obviously, you all know it would be viscoat, no financial interest. I remove the bubble, normally use methyl on the cornea, and I use viscoat in the eye. Make your incision, okay? Go ahead and do that. And then gently make sure that your CCC is complete. So I'm gently lifting the CCC and removing it with the help of a forceps. It's like you pinch a handkerchief off from there. And hydrodissection, of course, has to be very, very gentle. Obviously, there is no space. As you saw the clinical picture, that it's a very, very hard cataract. Now I'm going ahead and seeing what I can do next. Now, we have the overlay, and you can see that during phacoemulsification, another trick here is to use a brand new tip. Don't keep autoclaving the tip and use an old tip in a hard cataract. Make sure you remove a brand new tip and use a brand new tip for such cases. So you can see that gently I'm going around doing phacoemulsification. The hardest part normally in the nucleus is the central part. So you make sure you make a little bowl so that you can get a whole grip. And again, use more of viscoat elastic. So you can see I'm stopping, putting viscoat, stopping, putting viscoat. Okay, I'm specifically using the word viscoat because there'll be questions at the end of the procedure too. So I'm going around, okay, and then bringing it, and then chopping, going around, chopping. I use a sharp tip chopper, no financial interest again. Different lengths of sharp tip chopper are available in the market. Normally it's 1.25, 1.5, 1.75. Again, I've come out, put methyl on the cornea. That gives me also a little time to breathe, and then gets our pulse down besides the pulse of the patient. And I'll tell you why. So I'm going around. Now the pupil decides to come down, obviously, because it's taking time. Again, put viscoat. Viscoat itself will help you to keep the pupil well dilated throughout the procedure. So you can see that now I'm going around and now I'm getting all the pieces out, one by one, and then again coming out, putting viscoat and going around. So Lot of patience is necessary. Don't get impatient. Carefully, of course, do this. And then going ahead and again removing one piece. And then once the whole pieces are out, you can see that the bag is clear. Once then we go ahead and do IA, that's when we actually get time to breathe. Go ahead and put in a lens. Now you'll see one of the lenses, which I've never used this lens before. This is the first time I'm using this lens. So that was a little funny. I'll tell you the story later. Go ahead and make one more side port. There's no harm in making one more side port to remove the subincisional cortex, which is there below the CCC, which was done with the help of the femto. And then go ahead and put a lens in the bag. So you can see the cornea remains clear, and the lens goes into the bag, and everything is fine. Now, more interesting part here will be the next questionnaire that I'm going to ask all of you. And now the panel can answer this, no harm. How old do you think this patient was? Say that again? 93. Okay. Anyone in the panel, how old do you think this patient was?
How old are you?
Patient was older than me.
Oh, he's older than So he said 93. So maybe, yeah.
Yeah, Shreya?
Sir, I had to think before saying that the patient was older than me, so I'm guessing 60.
60, okay. Anybody else wants to say? Okay, so the patient is actually 62, right? That's one part. So not, you'd expect a cataract like that and a patient to be 80. What do you think was the vision in each eye? So you want to see the clinical picture again. This is the right eye, this is the left eye. So what do you think was the vision when the patient came to me? Anybody?
6'9". 6'9".
6'12", okay.
See, these people normally are high myopes or they are diabetics, and their vision actually keeps on degrading, but they still see. So that's the reason they don't come to you.
Yeah, so the vision was 6'18",
Yeah.
which is correct, and 6'12" in the other eye. What do you think was the profession of this patient?
Jeweler.
Jeweler.
Yeah.
Anybody else? CA or doctor, okay?
Okay, the most of the patients that I have done of this kind, they are ministers in the central government.
Ministers in the central government.
Cabinet ministers.
So you'll be surprised, he's an operating ophthalmologist. And that will explain many things what I was doing during the surgery. So he's actually operating ophthalmologist, okay? So now serious questions. How much BSS do you think I used? So I used 1.5 bottles. How many viscoelastics do you think I used?
Five.
5. अरे तेरे को तो free मिलता है.
हाँ, मेरे को
तेरे को
free मिलता है. How many did you use?
3.
3, okay.
And I used the Rayner lens. So when I said I've never used this lens before, because the ophthalmologist came with that lens in the hand and said, use this in my eye.
Okay.
And when I was operating, he was actually telling me what to do. So put the viscoelastic. I've used Rayner lenses before, but I've never used this. So he said, put viscoelastic there, and then you inject the lens. And I said, okay, and it all went fine. So what do you think was the first day post-op vision?
Basically, he must be listening to your talks. Vision was 6'6", obviously in Kumar's hand.
Yeah, so that's correct. The patient was very happy. When he called me in the evening, I got nervous. I said, "Kuch dikhta hai kya?" So because you expect SK, etc., etc. He said, "Nahi, dikh raha hai." I said, "Theek hai to fir." And he comes next day and he was 6/9 unaided. He was very happy because he was N6. So I was surprised. I think the Rayner lens does quite well. And luckily, he came back for the other eye to me. Thank you for your attention.
Thank you very much. So any questions, or the take-home message is that you have to be patient with a hard cataract. Nowadays with the new machines, even if you don't have a femto, obviously I would prefer, these are cases where I also showed you a black cataract, and where my fellows or one of my juniors said, "Sir, we'll do an SICS," and we had actually made the incision, the surgery that I showed. But I said, no, my ego came in. I said, no, I have to do a phaco. So actually, if you're doing phaco in the proper plane and using BSS or BSS plus and using Viscort or chondroitin sulfate, I think you do get. The main thing is to break the backbone of the nucleus. That's the main thing that you have to do, and be patient. The fluidic-based machines which you have, you can go to higher vacuums and things like that. You are able to get good results. And it's often when your head lean comes down and you're left with the last piece that you kind of, or you're doing an IA that you tend to get a rent. So just lower down your parameters. Yeah, go ahead.
Yeah. So one question, when you did a capsulotomy with flax, why didn't you further use it for the nucleus division? You did a flax capsulotomy, no?
Even I used it for the nucleus also.
But
Okay.
I have the Zimmer. It's like the catalyst. You have to increase your energy for, depending on the grade of the nucleus.
Okay, so you use flax for
Yeah,
the
yeah, yeah.
nucleotomy.
Yeah, yeah.
Okay, didn't seem as though you'd used it.
Obviously, because it's so hard.
Okay, secondly is
See,
what kind
basically,
of
I
chopper?
don't know whether you were there at that time, but the case that I showed, you could see the air bubbles coming up.
No.
So what that meant is that it had penetrated the bottom. Yeah, go ahead.
Second is what kind of chopper did you use? And also the tip that you used, it was the normal tip, you didn't use a Kelman or a balance tip.
So it's a sharp tip chopper made by Epsilon. It's on my name. It's called the Kumar's chopper. It has different lengths. It's a sharp tip. As far as the tip is concerned, I have a Veritas. So I can't use a bent Kelman tip or anything like that, what you can use on the other systems.
you can have Kelman tip.
No, a bent tip. So I use So I use a normal tip, which is 15 degree or 30 degree, depending on what. I don't use a 45 degree. But important take home again is to make sure you take a brand new tip for hard cataracts.